this was one of the pieces of information that really set this study in motion. This is some work done, Lynn and Adamson, 2003 originally, talking about different trajectories. So you have the cancer trajectory. Once it begins to happen, it's fairly predictable and fairly fast. You have what they characterized as organ failure, where people are in and out of hospital, each time perhaps not quite at the same functioning level as before, and so when you look back, you can see this gradual deterioration. Sometimes death happens unexpectedly during one of those exacerbations. And then they talked about the prolonged dwindling of frailty and dementia. And the time spans can be very different. This could be as short as 3 months, it might be 6 to 7 years, in fact. The interesting thing was what Palliative Care Australia said about this, and that was that they saw them as being roughly sequential, with cancer peaking around 65, organ failures, deaths 75, and the frailties and dementias 85 and over. And given what I showed you about that huge shift coming in the age of deaths, that's the question we're asking, is what might trajectories look like with the shifting that's going on? The other piece of work, and Michelle was involved in this very interesting work on independent life expectancy, and a very elegant study. You know, if you look at this, a female New Zealander aged 65 can expect to live about another 10.6 years independently, and another 10.7 years with functional limitations, of which half she needs daily assistance. And so again, there's this sense of what is it going to take to cope with frail elderly and many more of them. So this particular study, we looked at all deaths in the country that were that occurred and were registered in 2015. So the mortality data is central to this work. That's actually the reason why it's 2015. At the time we were doing this, that was the most recent mortality data available. And then we linked what we could. So Cancer Registry and the National Minimum Data Set, which is the hospitalizations, go back something like 25 years. The interRAI data was the shortest one. That was about 3 years at that point, other than a few early pilot assessments. And the question was, who is not reached by specialist palliative care, which is hospices and hospital palliative care teams, or by aged residential care? In other words, what is the burden on primary care and on district nursing? And can we try to identify what that is and see where the gaps are? So looking at these trajectories, there were some other things in there. I tried to look at a minimum data set for hospital palliative care, which turned out to be particularly difficult. And we also looked at funding flows for end-of-life care, because each of the places that people end up using are funded differently and aren't necessarily linked up. So these were the data sets we put together. The mortality data is central to all of this, particularly in terms of saying we wanted one point of truth for the date of death, for ethnicity, for the DHB, for a number of things. And so that's why the mortality data for us was absolutely central. I've mentioned the Cancer Registry, but inpatients, outpatients, mental health labs, farms, PHO enrollment, Socrates, the disability support database. June knows these data sets extremely well. I'd worked extensively on the mortality collection, and I'd worked with the aged residential care data, interRAI, and the hospice data. I've been working with them for 5 years on their data. So we were able to collaborate and put our understanding and knowledge together, and for the first time, see what all of these looked like for people at the end of life. The hospice data is not usually in a national collection at all, and the aged care data is not always easy to get access to. So, some of the initial insights, and then I'll show you the trajectories that we were able to identify. Oops. This one is quite simple in retrospect, but something I've been wanting to try for a number of years. Looking at everybody who's in the cancer registry, and then having a look at what they died from. So the interesting thing is the dark blue are the people who are in the cancer registry and die of cancer. And I come from Africa, as you can hear in my voice. This for me looks like a hippo shape, the head and the body. The important thing though is how that tails off at older ages. What was really interesting when we said who else is in the cancer registry but died of something else, we get the pale blue, and it's almost like a cloak on the back of the hippo. So the older you are, the more likely you are to die of something else, not the cancer. Right? And so that's an important feature. I'd seen this hippo shape many times before in the hospice data, and you'll see it when I show you the hospice part of this today. So that is an important new finding in this. This one, we'd done a pilot study on Auckland District Health Board linking the data, so I had seen this in the pilot. Huge shock to everyone who haven't seen these kinds of things yet. This is the use of aged residential care by those who died in 2015. Overall, 44% of people who died used aged residential care. That's much higher than we think of in just even our collective understanding of the end of life. But it's this shape that is such a surprise. By the time you get to 95 plus, more than 80% will use aged care, and it reaches almost 90% by 100 plus. And it's not part of our collective conscience that people will all, or many of them will end up in aged care. We tend to think of it as a fairly small sliver, not as this inevitable end point that it seems to be from here. By the way, this is, we can see who died in residential care. We can see who has a subsidy, and of course there's all sorts of interesting stuff about who's in there without a subsidy. And we can also use the interRAI data to find some people that are paying privately. Here's your interRAI data. Most of my graphs are by age. Healthcare, I've been in healthcare since the early 1990s. Every service has a shape by age, and it's usually pretty stable. And your interRAI data fills in so many gaps for us about these oldest people. The dark blue, the dark purple here are people with an interRAI assessment and using aged care. This little group here, this was done in 2015 when the long-term care facility assessment was just coming in, and so it wasn't yet fully embedded in the data. And we were able to say these people would have had a long-term care facility assessment if it had been compulsory at the time. And we can also see who had an interRAI assessment but didn't go into aged care at all. Probably ended up with some kind of home care. At least we hope they did. So very useful for us, for the older people. One of the most interesting parts, and I credit June with this, we knew that dementia was important, and some of the studies that were being done in the Auckland region were showing us just how important it was to think of dementia first. But all we had been able to see up until then was dementia in the cause of death data, and that would have given us about 2,400 people who died of dementia. The question is, who's dying with dementia? Because often on the death certificate what you're seeing is a pneumonia or a fall or a respiratory failure of other sorts. So June was able to use the national collections, and that's this turquoise bit all the way through there. We were able to identify people with dementia. They'd had an admission, they'd had an outpatient event, particular pharmaceuticals, And there is a technical note on this if you want to use it and follow it through. We were then able to use the interRAI data, and interRAI overlapped with the national collections by this part here, the hatched part, and then interRAI alone gave us information on another group there. And we were able to use both the diagnosis field as well as the cognitive performance scales that were in there. And so instead of having about 2,400 people who died of cancer, we're able to see 8,500 with dementia in this data set. Way more than we had ever thought there were. If you look at that by age, it has a particular shape. The dark blue there are the ones that we can see from the mortality data. The turquoise here is everybody else added through these other methods. And you can see that by the time you get to 95 plus, 50% of the people were already dying with dementia. Big surprise to everyone who saw these results. This point that seems to go up at 100 plus, we believe that's simply that the assessments weren't being done on some of the oldest old. And certainly from a projection perspective, I would imagine if those assessments had been compulsory beforehand, we would have seen more of that coming through. We tend to smooth this out and use it just at that level for that final point. So, big surprise from this as well. And out of that information, and working through what these groups were utilizing, we developed 5 groups that we're going to look at. At the top, in purple, you can see the dementia group. In red now, the hippo shape that I talked about, that's the cancer deaths. The people who have cancer but die of something else end up in this dark blue that lies on the back of it. But also anybody who had an interRAI assessment or you ended up using aged residential care is in that blue. So we've used the phrase chronic disease, but that's kind of shorthand for chronic disease and frail elderly, with frail and elderly being the important words in that. What that interestingly leaves us, I mean, this shape here for the sudden deaths, as an actuary, I know that well from insurance terms. We call it the accident hump. It's the years of suicide, accident, violence. And so that's a large part of the early adult years, particularly for men. What we're left with then is this pale blue part, which has a number of things, and it's actually quite a hard group to disaggregate. In there are congenital diseases and people living longer with congenital conditions than they ever have before, cystic fibrosis, for example. But it's also got a number of other things in there, a lot of the cardiac, earlier cardiac stuff. So these people may have chronic conditions, but they form part of a group that we call need and maximal need, and that goes back to the work that was done on the need for palliative care. These are people falling within the need for a palliative care approach, and the sudden deaths are the ones that we identify as saying, probably not, probably no time to have done anything. All right. So, a very interesting 5 groupings. What you're seeing, I meant to tell you, this black line on these graphs is, on the right-hand side, the number of people in each age band. So very few deaths in these early years, huge numbers already in the kind of 80 to 85 type bands. And that's, of course, what's going to change. That's moving further to the right in the future. Okay. And if you look at these last few bands, it's moving into territory where it's not cancer, it's either blue, chronic disease, or purple, dementia. There's not a lot of other space for other things in there, right? So just keep that in mind. As we start looking at the groups, those are the 2 that are going to grow the fastest, dementia and chronic disease. When we look at the actual numbers in each of those groups, the surprise for everyone was that already dementia turns out to be slightly larger than cancer. That's not the way we have treated it from a policy perspective. It's not the kind of general sense of the priorities. And so a very important finding around the people dying with dementia already. It's a very hidden condition. People are not as voluble. You don't have focused groups arguing for more care. And so it's been a kind of hidden disease in many ways. But yes, dementia turns out to be slightly higher than cancer at the moment, with chronic disease there in third place. We can look at all of these things. Here, for example, is the aged care subsidy and the use of aged residential care by the 5 groups. So dementia, cancer, chronic disease, and then need and the sudden deaths. Dementia, something like 85% of people in the dementia group used aged residential care at some point in their trajectory. Interestingly, of the cancer group, it's getting up to around 27% using aged residential care. We've seen that in the mortality data, huge increases in people with cancer dying in aged residential care as opposed to dying with hospice. And in chronic disease, 50% of them using aged residential care. So those are the 2 groups we're expecting to see grow substantially. You can start seeing where some of the pressure is going to come through in the system. I keep moving too far back to, there it is. Here's interRAI assessments. Almost everybody in the dementia group had an interRAI assessment, and I suspect if we did this now, it would be everybody. So that's just the loss of a few while it was becoming compulsory. Cancer, around 40%. And with the chronic disease group, it's well over 80%, 83% have had an interRAI. So that tells us just how important the interRAI data is for understanding these groups, and understanding them obviously in much more depth than I can tell you today. We were able to look at utilization of services. So as I said, given that we've got all of these different data sets linked for the first time, we were able to look at the last year of life, LYOL, the year before that, 2 years prior to that, and then the 5 years before that. It just happens to be a convenient way to graph it here, but obviously we can look at the detail. So just a few visual things as they come through. You'll have the slides later, and I'll actually put all of them in a pack that you can have a look at and share. But look at days in public hospital. Cancer and chronic disease utilizing the most in their last year of life. Days of aged residential care subsidy. You can see the dementia usage. You can see the chronic disease usage here. Emergency department admissions. Cancer and chronic disease utilizing it the most. Outpatient visits, cancer. So we can actually run through all of these and have a look in a lot of depth at who's using, which groups are using, and get some idea of what the future where the pressure points are going to be. Here's days in a hospice IPU, mostly the cancer people utilizing hospices. And one of the pictures that we particularly used with the ministry was this one. If you look at the different places or beds that people are being transferred to, and DHBs have become very good at discharging from public hospital into aged care, you can see on this scale, the dark blue is public hospital, the green is aged residential care, and the red is hospice. And so you can see this bed usage that's going on at the end of life. And some grimacing, yeah. We were able to do some time before death studies, like first admission to aged care, first referral to hospice. In the past we tended to think of aged care as being home or a long-term place. It isn't any longer. There are some people, this is prior to year 10, there are some people who are in there. I think the longest one in the data was something like 19 years. But very few of those, they're kind of working their way through the system. Most of the admissions at the moment are now very close to death. And look at this in the last quarter prior to dying. By no stretch of the imagination is that home. This is an alternative to public hospital, usually. So, big shock, I think, for everyone who saw that. Here's taking just that last year and looking at the admissions, and look at the number that come in the last 3 months of life, including in the last week. Again, this is not home. We can look at the hospice admissions on the same 1 year scale, and again, many of them coming in exceptionally late. This is much later, I think, that hospices have a sense of themselves, and it's the problem of averages. In aged care and in hospice, people tend to have looked at the average in the past, and it's hugely skewed by a few people who are there for a long period of time. It's really important with this to do the whole distribution and have a look at the detail. We were particularly interested to comment on public hospital and ED events. Interestingly, the dementia group have quite a large group, about 30% of them, who don't use public hospital or ED at all in the last year of life. The other groups tend to, particularly cancer, almost everybody there is using. Again, pictures by age tell a much richer story. Your ED-only usage is largely here in these accident years. Big group here who use both. And as you get to these oldest ages, a massive tailing off in both ED and public hospital usage. That's the effect of going into aged care. We're able to look at that a lot more directly as well. We tried to work with hospital palliative care to get a set of data that would tell us who had received palliative care while in hospital. They don't have a national data set, they don't have data standards. We eventually had to walk away from that. But I did manage to get some estimates from them for who they had seen. And so we have an estimate for the year. It's very much an estimate, but it looks like this shape. It's kind of like, a bit like a hippo shape, but a little flatter. And I presented this to the Palliative Care Advisory Panel recently, and the round table people who were there had been starting to look at palliative care and hospital data. Said, yes, that's exactly what they're seeing too. Hospital palliative care is not seeing so many of these older people. And they'd been wondering about that. So 2 points of data were able to tie up very clearly. And so we can see this estimate of hospital palliative care, and I'm going to show you in a moment the hospice data, and then try and put the two together. Just before we go there, the last thing I want to say about this institutional bed story is we were surprised how many people end up in some kind of institutional bed, and by that I mean either a public hospital bed, an aged care bed, hospice IPU. We tend to tell ourselves that people will die at home. It's kind of the myth we're all telling ourselves, but they don't. If you look at that, 91% of the dementia people die in a bed somewhere else. Cancer, 69% of them, 81% of those with chronic disease. So I think there's a shift that we have to make in terms of our understanding of what these trajectories look like. And of course, with the aging going on, the pressure on the system is enormous. You look here, it is almost linear from age 10 to age 100. And with the immense growth that's going to come in these last few age bands, the question is it even viable to talk about keeping them out of our institutional beds? You would have more understanding of that than I do, but certainly from a data perspective, I look at this and I wonder. So let's look at the palliative care from hospices and then overlay aged residential care. And finally get to look at that gap that primary care is taking care of, we hope. Here's the hospice usage. Hippo, red hippo shape. Peaks at around 50%. It looks just like the cancer shape in many ways. Hospices have known this for about 5 years, so this part wasn't a surprise. But we were able this time to see what proportion of their people were in each group. Cancer, 78% of that group are referred to hospice. Interestingly, 22% not. That's the interesting question. Were they coping well? Were their primary teams coping well? Or is this something that we need to be looking at? But they knew that they had very low numbers in these other groups. We can see the use of hospice IPU, and it's greater in the cancer area relative to the overall grouping. And we can also overlay the hospital estimate and see. And so this is the first time we have an estimate in New Zealand of what specialist palliative care is able to see. And my sense is 38%, 39% of all deaths are receiving specialist palliative care. The question about the others, I've overlaid on here the need for palliative care, so very few of these sudden deaths fall into any of the need calculations. This group here, there are quite a few deaths from conditions where we might not have had a chance to offer palliative care. But this cream part in these areas, that's the gap between specialist palliative care and the need. And the big question is it being met well by the primary care teams or not? If we could link the data, we would have a better understanding. Okay. Here's what it looks like by age. We're doing really well in these early adult years. I'm not too worried about the children. We weren't able to link the Starship palliative care teams data or the National Palliative Care, Pediatric Palliative Care Network. But my sense is that they've got good coverage in those very young years. It's from around the 50s onwards that we see this enormous gap between specialist palliative care and the need. And that's, of course, almost exactly that green shape of aged care. So in the next few pictures, if we do it by groups, what you've got here in red is when they see hospice only. Red and green is when they're using both hospice and aged care. And green only is aged care only, right? So if you look at here with cancer, you've got this huge involvement of hospice, but also some involvement directly of aged care on its own. Whereas with dementia, of course, it's the other way around. Hospice is only there for a very small proportion of the deaths, whereas residential care is the place we need to look to for good palliative care. And that's why it's been so important thinking about this in the upcoming changes in contracts, just how important palliative care is in this setting. Here's the picture by age, and I think this is probably the most important slide out of the study. Here's hospice, the red hippo. Here's the overlap between hospice and aged care, but here is aged care on its own. And it's how hospices are able to support aged care to provide good quality palliative care. That's the issue. Hospices, I work with them extensively on this, and the question of how we can demonstrate who has been reached and what kind of services, what kind of coverage there is one of their challenges at the moment. But from a health system perspective, it's the cream here that we need to be asking ourselves questions about. Are they being well looked after in primary care by their district nurses, or did they fall through the gaps? There have been 2 Voices studies, one down in Canterbury, the other one is up in Auckland DHB, asking families afterwards about their experiences and where they think the gaps were. And in the Auckland one, we're able to attach that to linked data and see what services they used, and that data collection is just finished. The analysis is still underway. We showed some stuff to the Minister in February on ethnicity. NZDEP, which June gets deeply involved in the work on. And just to give you, I'll just give you one example here. If you look at it by ethnicity, the group that has the highest coverage by hospice is in fact Māori. So it's a bit of a myth out there that Māori don't use hospice or aren't seen. They're the group with the highest coverage. The group with the largest cream at this point is actually NZ European. But aged care plays a huge role in this. And so if you superimpose the green, with the NZ European group, you have this high usage of aged residential care, and so their cream has become a lot smaller, whereas with Māori, fairly small group using aged residential care, and so the burden on home and the primary healthcare teams is much greater. Okay. So very interesting to unpick this and really look at who is not being seen by specialist care or by aged care. And I'll leave, you'll have the slides, you could go through them in a lot more detail. We've just completed some work on projecting some of this through to the future. Projecting, not predicting, it's projecting, so if nothing changes, then what? Of course, something will change simply by having done the models, but let's just have a look at some of this. I've talked about these deaths increasing at oldest ages. That black line is deaths in the study. The white dotted version is deaths by 2038. Just very sobering always, these big increases coming in the numbers at the oldest ages. And if we take a look at that using Stats New Zealand's latest projections for the Ministry of Health, that's what it might look like. Dementia, almost doubling from what we saw in the study over the next 20 years. Cancer does go up, but by a smaller amount. It's the chronic disease and the dementia groups where we see these potentially massive increases. What else might happen? I mean, that's the subject, I think, of an entire discussion we could have about what else might people die from. But this is, in a sense, the consequences of success. The more we're able to cure the cancer, the more we're able to help people live longer, we're propelling them into these other trajectories. And they're going to need to die of something. I'm one of those baby boomers, so yes, it's a very sobering thought. Just some last things that we've just recently done, which I thought you might find interesting. Having this data, each person, every day, for the last 3 years of life, we were able to say exactly which services they used and where were they. Because this has been a study taking that data and talking about time in the community. What are we asking our NGOs to do in terms of coping with this? People like Alzheimer's New Zealand, for example. What kind of burden might they end up with? So this is the last 3 years of life. What I'm going to show you, this one is all the groups together to start with. So it runs from about 1,000 days out all the way through to death. Year 3, year 2, year 1, death is at this point. Green is aged residential care, as we've been looking at. Blue is public hospital. Yellow is at home with hospice help. The red is utilizing a hospital inpatient unit. And cream is I'm at home. We can't drill down yet to what help they were getting at home. But if we could link by the NHI numbers to some of those other smaller sets around the country, we could see. And that's what we hope people will do in their own DHB. So here's all the groups together. I'm just going to go in reverse order through the groups quickly. There's the other sudden deaths. So they are utilizing hospital a little bit beforehand, maybe in and out, various things happening. But you can see right at the end, but not everybody makes it even into hospital. Okay. There's the need and maximal need group. This one's really tough to get to grips with who is in there helping, because there's a little bit of hospice support there. There's some public hospitalization, but by and large they're at home. And so it's interesting we don't know enough about this group and exactly where they're getting help from, or if they feel like they are not getting enough. There's the chronic disease group. So you can see the big usage of aged residential care beginning to happen. There's the cancer group with this large hospice at home support. And here's dementia. Interesting, when you put them all on the same axis again, the 5 different trajectories and the very different patterns of use of being at home, and therefore the kind of support needed. And just, to say once again, these are the 2 groups that are going to grow. Chronic disease and the dementia group will about double. And I don't think we've begun to think about where people might go instead, or just how we're going to cope with this kind of volume coming through within the next 20 years. So yes, fabulous data always probably generates as many questions as it provides initial answers for, but it's been fabulous, and thank you very much for your interRAI data, Michelle. It was a big part of identifying these dementia people, and therefore their importance to the system. And to end off with, I saw this lovely South Island Alliance guest editorial this month. The data is the new scalpel. And for understanding our system and therefore doing something with it. Wonderful opportunities to do so. Any questions?
Anyone any questions for Professor McLeod? We'll put the people back on when you see them type any questions in. Yeah?
I don't actually have a question at all. I have a comment. I run 2 NASC services for older people, and it's been really exciting because what we actually see and what we talk about happening, and people sometimes tell us, no, you're not right. It just reflects in that data what we see on a daily, weekly, whatever else service. So thank you for using our data, and we've been pilot sites, so we've been using it for 12 years. It's really exciting to see that data showing what we see, so thank you.
And that's exactly what I love to hear, is how it shouldn't show us anything we don't have a gut feel about.
Yeah.
But actually seeing the numbers and confronting them hopefully begins to change the
And
support.
hopefully there are other people there in the wider system who will see them and suddenly say, well, yeah, you're right.
Sorry, go on.
It's fantastic work, and great to see identify this dementia group, which is growing. My question is, okay, we have to die from something, but is dementia actually the source, or there's a causal relationship between having dementia and dying, as compared to cancer or chronic disease? We can actually see that they definitely contribute to the death. But how does dementia actually contribute? Or they die from?
I think you're going to need to talk to your clinical people about that in more depth, but it's dying with dementia, not necessarily of. And so often we just can't see, if they died of heart failure, or they died of renal failure, or lung failure, or I mean, the interesting thing, showing this to someone one day, their first reaction was, we have to prevent the dementia. and my sense is, not necessarily, because what else do we want them to die of? In fact, my years in the ministry, just to share a story with you, I can remember a wonderful young person who'd just been sent to the ministry and was working on non-communicable diseases and wanted to reduce non-communicable diseases by 40%. And my first reaction is, well, what do you want them to die from? And people often, surprisingly in our system, are shocked by talking about the inevitability of death. And what else might it be if we somehow find some ways to reduce the dementia burden? What else would we have as we get into our hundreds? I don't know. Doesn't look like a very exciting picture, to be honest. But yes.
Possibly so improving standard of life.
Yeah, that's right. Yeah, this which can take a long time. Any other questions you would like to ask? Oh, is it? Is there a chat? Where? Sorry. Somebody got a question on the Zoom? Do you want to put your microphone on and ask? Go on.
Hi, Heather. Hi, it's Natalia from Oxford. Thank you so much. One question. Can you hear me?
Not very well.
Not very well.
Would you like to type your question in, and then I'll read it. Oh, here we are.
Can you hear me now better?
That's better. Yes. Yes.
Well, we found that many DHBs found PHOs to provide palliative care in the country. So the PHOs would have some data energized. Have you done some work with the PHOs, or are you planning to? Because that is really interesting. We really need to know what is happening in the community with that screen.
There isn't a national set of data that tells us who is being seen at what time. We only know whether they're a member of the PHO on a once a quarter basis. So the lack of being able to see it nationally makes it impossible for us to link anything at that level. I think this is the next step in this would be those DHBs who want to take it in and drill down, and therefore to insist that their PHOs or other groups, their district nursing information comes into it, because you can unpick this further, but standards, national data, all of those good things, we don't have them. And we need them in this kind of area. We don't have a way of saying even, was somebody seen by hospital palliative care? Were they also seen by hospice? Are they in aged care? Even our aged care data doesn't tell us everybody who's in there. So, yeah, big data issues, and well, it's why it's always such a joy to work with interRAI, because your data is a joy.
Please say that. So keep saying it. Thank you. Yeah, no, you're really in me now. Michelle?
I just want to ask about comorbidity, because you kind of group them into, distinct group of dementia, chronic conditions. Have you looked at, people with multiple health issues?
There's a really nice graph of what those comorbidities look like from some work in other countries. Yes, I mean, if we could take the burden of disease groupings and impose them on this, we'd get to something like that. It's really, those names are just very large groups, as opposed to saying, yes, but it's feasible to get in there and say, let's identify everybody who's had diabetes, for example, and then have a look at trajectories and things. Yep. Yeah.
This is national data, isn't it?
Yes.
So, I remember with previous work you said use the national data for local projections. Is that the case with this data as well?
Yes. With only 30,000 deaths, we haven't got enough data to do those patterns by region. But those graphs that show almost like paint dripping off the end, I've looked at that regionally, and it looks just the same. You can barely tell the regions apart. So my sense is that the national pattern is good enough for most high-level things. But yes, we know that the issue in Central is always that you have greater usage of hospice than other areas do. And so that's the point where you want to translate that on top of this. 5 years of data, you would have enough points, but not just 1 year, unfortunately.
Trish, you have a question?
Mine's actually, to an extent, has been answered, but I was just reflecting, it looks like a highly institutionalised care model going forward, and I was going to ask about regional variation, but you kind of answered that, but it does, to me, it's a bit bleak given around honestly, the trajectory. That really highly institutionalised model is prevailing and seems to be the model of care that we're probably unconsciously.
I think it's unconsciously,
Yeah.
because of the lack of joined upness.
Yeah.
One of the related things to this, or in fact, let me answer your question about usage around the country. The Midland region has a much more community-based model. Central has got this highly bed-driven hospice usage. But the interesting thing is that even though Midland has a more community-based hospice model, they're still using the beds somewhere else. So in fact, and that's ultimately the issue. We've got a number of different beds that we're busy moving people around. And the other interesting bit, I had some discussions with St. John about this, because we can see the transitions. We can see how many transitions people are making. And there are people who make 150 transitions in the last year of life, in and out of places. And you look at this and you say, this has just got to be wrong.
This is wrong.
Yeah. And from their side, they're looking at this and saying, but we're making those transitions for people. We're picking them up here and taking them somewhere else and then bringing them back to another place and then having to go and see them at home and then readmitting them. So, yes, I think the important thing about data like this is that we actually put all the parties in the room to realize that the trajectory at the end of life has become highly institutionalized. And if we're going to do anything about it, we really need to solve it collectively, not in silos.
And it's wider than just health. It's family and societal expectations that we don't want to try and have those people like we did. Even 10 years ago, I would say that there was less of a willingness to have people die at home. They want to push that off to somewhere else, which is really sad. So it's a constant struggle.
Yes. So there's a comment here from one of our educators, Robin Matlin in Christchurch, who said perhaps the PHOs consider the use of interRAI assessments. So one of the projects that interRAI is looking to try and get off the ground soon is our ability to be able to share an interRAI assessment in a very simple, easy way with primary care. So we've designed a relatively simple dashboard that's just 6 pictures of what we call caps and outcomes, for those of you that understand interRAI, that will give you a very easy to look at red to green picture of an individual person. We've just got to work through the process of actually getting that to primary care and then helping primary care to understand it. So we have got plans to actually try and share our data with primary care. It's systems and technology that we need to get around. Any other questions for Professor McLeod?
It might be difficult to identify people that choose to die at home, especially cancer patients. Sometimes they prefer to die in the intimate of the family. So how?
I think our understanding of how many people are able to die at home is very different to what we're actually seeing when we look at that at the real data. And I think we have to think quite carefully about what it is, whether people feel a failure if they couldn't keep that person at home. In some countries they started trying to make it a marker of quality, and it's not, because actually there are times where it's appropriate for somebody.
And some people, my father said, I do not want to die at home. I don't want to do, because that would, teach my mum, because I want to die.
So, lots of complicated things around that, and the ability of families to cope is a big one. Many questions.
Any other questions? No? Well, thank you very much. I'm attempting to sum up, which will be quite difficult, but I think I'd start by saying that you actually started in 1876, which I thought was very impressive. And took us all the way to 2038, so it was a huge span in terms of the years that you were looking at. And that you really that you drove home some points which make you feel a little vulnerable. Is that it's really organ failure and dementia and chronic disease. This is the large growing groups for the future, and that we'll all end up in one of those green, cream, purple or groups, and that. Yes, just make you think about your own personal situation. I think if you were you busted some myths, particularly about whether people die at home or don't die at home, and I think that's really important, not just to bust the myth, but to actually be able to evidence that and show that, because people do have these things in their heads, these views in their heads, and to actually see the data and be able to show really what happens is very very helpful for us. You talked about the big gap and whether that big gap really can be managed by primary care. And we here at TAS we have quite a lot to do with primary care in terms of particularly the primary care contract. It's really useful for us to have that picture in terms of the need that's out there and really whether primary care can get there. And you also busted another myth around the use by Maori and hospice, which again was one that I think people often have thing in their head that that's how it works. So I really wanted to say thank you very much for coming here and for giving us your time and all that fantastic information, and for being so positive about interRAI data. Thank you. I couldn't possibly leave without saying that. So this is just a little present from us to say thank you. You get a few interRAI goodies. We have interRAI goodies. So thank you very much for coming to speak to us.
It's a great pleasure. Great pleasure.